Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. Yesterday we learnt about burns, and we have seen whenever there is deep or full thickness burns, the whole skin, including dermis, is lost, and the wound heals by scarring, and the scarring can lead to deformity. To prevent this deformity, we have to do early tangential excision of the eschar. So in deep burns, there will be a scar. So once the patient's general condition is stabilized, his systemic status become normal, then you have to plan for surgery. So as early as third day to seventh day, you have to plan the surgery. You have to excise by tangential method. The eschar is excised up to the living area. So that means the viable skin that is identified by bleeding, by punctured hemorrhages, and you do grafting. So this grafting helps to reduce the scarring and prevent the deformity and contractures. That is why we are including skin grafting in this burns topic. So how the skin grafting helps and what are its other additional uses? Let us study now. So such wounds, if they are left like that, they become scar like this, and the scar may get contracted. Skin grafting prevents all that. So after skin grafting, it becomes like this. So there is no contracture. Autograft, allograft, heterograft, or genograft. We have learned about those things in the previous class. So autograft is commonly practiced. Allograft is done as temporary biological dressing in large extensive wounds. After 2 to 3 weeks, the allograft is rejected or it is removed. Then autograft is done over that. So indication for skin grafting: large wounds or ulcers, like bed sores, traumatic wounds, soft tissue loss, then burn wounds, post-operative excision of large skin tumors, scars and their complications. For example, if this ulcer heals, it forms a thick scar here with contracture. So what you can do is you can remove all that scar tissue till the normal pliable tissue is obtained. Then you can do grafting over there. Then flap donor defects. Sometimes in skin grafting, you take flaps. So whenever you take flap, there will be a defect. So that defect can be closed by, again, skin grafting. It may be confusing for you here, but anyway, after 5 or 6 slides, you will understand what is a flap, what is a graft. Then for aesthetic surgery, skin grafting is done. Breast and chest wall reconstruction, then face uplifting. Types of tissue grafting: they are divided into grafts and flaps. Grafts means tissues that are transferred without their blood supply. So there is no blood supply. You just take a slice of skin and place it somewhere. That is called graft. There are 2 types: partial thickness graft, full thickness graft. Partial thickness graft means is also called a split skin thickness graft. Epidermis and part of the epidermis is taken here. This is called a 3-dish graft. Full thickness graft means the whole thickness of the skin, including the epidermis and dermis, are taken. This is called Wolff's graft. Then the other grafts being not only about skin, the other tissues can also be grafted, like nerve grafting, tendon grafting, Then flaps. Flap means tissues that are transferred with blood supply, with intact blood supply. So for the time being, you remember this point. Flaps means it is skin that is transferred along with their blood supply. Physiology of skin in relation to skin grafting. Skin is having epidermis, outer layer. It contains labile cells. The labile cells have good regenerating capacity. If these cells are lost, they are again replaced. They doesn't contain capillaries or nerve fibers. Epidermis has no capillaries, no blood vessels, no nerve fibers. How epidermis survives then without capillaries? It survives by imbibing fluid from the dermis. So underlying dermis will be secreting fluid. So by absorbing that fluid, the epidermal cells survive. So there is no direct nourishment from blood vessels. So what do you understand by this? If you take away the epidermis and place over a raw area where some fluid can be imbibed, the epidermis survives. So these are the characteristic features of epidermis. It contains labile cells, that means it has great regenerating capacity. No capillaries, no nerve fibers, but survives only by taking fluid from underneath tissues. Dermis. It contains elastic tissue and is responsible for the texture and strength of the skin. It contains numerous capillary plexus and blood vessels. This plexus is derived from vessels in the subcutaneous plane, which run horizontally. These subcutaneous vessels are derived from perforating vessels of the underlying muscles and facial septa. For example, the dermis here. The dermis here gets its nourishment from underlying subcutaneous blood vessels. The subcutaneous blood vessels will be running horizontally like this. From them, there will be vertical growths into the dermis and they will be supplying the dermis. And the subcutaneous blood vessels, they are derived from the perforating vessels coming from the muscles. So there are vessels in the muscles. Those vessels, they give off perforating branches subcutaneously. These subcutaneous branches, they run in the subcutaneous tissues and they run into the skin. So now what do you understand by this? If I remove a block of tissue here containing skin, subcutaneous tissue and the underlying muscle, with the blood supply that is coming to the muscle intact, so the blood supply that is coming to the muscle is kept intact, I remove a block of tissue here. The whole tissue can survive because the arteries supply the muscle. From the muscle, the perforating branches come and they produce subcutaneous blood plexus. From the subcutaneous plexus, the blood vessels penetrate the dermis. So this is all a block. So you can remove a block of tissue because the nourishment of the overlying skin is derived from the muscle vessels through subcutaneous vessels. So this is how the vascular plexus is there. This is the subcutaneous tissue. You can see the perforating branches. These are coming from the muscle. So there is subcutaneous plexus like this. So from this plexus, the vessels, they penetrate the dermis and ramify in the dermis and form a plexus in the dermis. So it will be there only up to dermis. But in the epidermis, there is no blood supply. So that is why you can, as a unit, you can remove the skin, its underlying subcutaneous tissue, and its underlying muscle. It survives if it has its own intact blood supply to the muscle. So this is the skin structure. The epidermis is in wavy form and it dips into the dermis. as hair follicles, as sweat gland ducts, as sebaceous gland ducts. And this is the subcutaneous tissue. So this is the epidermis, nourished by imbibing fluid from the dermis. And this is the dermis. It is nourished by dermal capillaries, plexus. If you remove the epidermis and part of the dermis, we call this as split thickness skin graft or partial thickness graft. If you remove the whole skin, including the dermis, it is called the full thickness graft. So when you take away split thickness graft from one part, that means this part is being lost. So what is being left behind? The left behind structure is the dermis, and with remnants of the hair follicles, with the remnants of sweat gland ducts, with remnants of sebaceous gland ducts. So these are all epithelial remnants in the dermis. These can grow and form, regenerate and form a layer here. So whenever you take skin as split thickness graft from any area, the leftover skin or the bed has epithelial islands. These epithelial islands, they regenerate and again resurface and cause healing. So the split thickness skin donated area heals by simple regeneration. But if you take full thickness graft, the donor area bed is subcutaneous tissue. There are no epithelial islands. So it cannot heal by regeneration. It will heal by only scarring. So this is to show you the split thickness graft, where epidermis and part of the dermis is taken. And this is the full thickness graft, where whole thickness of the skin is being removed. Split skin thickness graft, it contains entire thickness of the epidermis and a portion of underlying dermis. The donor site gets re-epithelialized by regenerating cells from the hair follicles, sebaceous and sweat gland ducts. So this is graft taken from this area. So it looks like this immediately after surgery. Then 15th day after taking the graft, you can see it is all epithelialized. Here, little bit thick skin has been taken. That is why it is taking more time to heal. So the donor site heal by re-epithelialization. This is after 3 months. Still after 3 months or 6 months, if you see, there will be even the pigmentation also occurs. So the graft, okay, that is about the donor area. So the donor area after split skin thickness graft taken heals by regeneration and epithelialization. The graft laid on the recipient area survives by imbibing plasma. So you take this graft and keep it over a raw area. So the fluid that's coming from the raw area helps it to survive there. Fibrin forms between the graft and the recipient's area. New capillaries grow into the graft in 48 hours. The fibrin gets organized by fibroblasts to form adhesions between the graft and the recipient area. As the graft lacks much of dermis, it tends to contract and has a poor texture which doesn't match with that of the surrounding skin, and so it gives cosmetically poor result. You can see here a split thickness graft is done here. So there is a lot of difference between the surrounding skin and this grafted area. Requirements for graft take. If you place a split thickness graft over a raw area, whether it takes up the graft or not, for that it should have, the recipient area should have these requisites. The recipient area should have good vascularized bed, that is tissue capable of producing granulation tissue, that is capillary outgrowth and fibroblasts. So only that tissue can take up the graft. For example, you take a split thickness graft here and just place it here over the skin. Will it take up? No, because the skin cannot produce granulation tissue. So it should be placed over an area where the wound is there, the wound is capable of producing capillaries and fibroblasts. Tissues having no capacity to produce granulations, like the bare bone, that means bone without periosteum, tendon, cartilage, necrotic tissue, irradiated tissues. They do not take split skin grafts. So if you want to put a graft over an area where the tendons have been exposed, the graft will not take up over the tendons. Similarly, bare bone, if the bone is exposed, then this graft will not take up. Similarly, cartilage, for example, nose, skin has been peeled off from here. The nasal cartilage is exposed. If you want to put a graft there, it won't take up. Similar necrotic tissue, because granular tissue cannot be formed, and irradiated tissues, because there is already the capillary thrombosis and obliteration is there due to radiation, so they will not take up the split skin grafts. Then other requisite is lack of infection, especially from beta hemolytic streptococci and Pseudomonas pycnius, because of the fibrinolysins secreted by them disrupt the fibrin bands. So these two organisms, they produce fibrinolysins. These fibrinolysins, they disrupt fibrin because they lyse the fibrin. So the graft cannot be taken. And there should not be any dead space or dead tissue. What is the dead space? If you place the graft here, for example, this is the recipient area. You take the graft from the thigh and place it here. So there should not be any air bubbles between the graft and the underlying tissues. It should be closely adherent to the underlying tissues. So there should not be any space between the graft and the recipient area. And there should not be anything between the graft, any dead tissue between the graft and the recipient area. Procedure: grafts are taken from the donor sites with the help of a dermatome, or that's also called as the skin grafting knife. The choice of donor sites being thigh, buttock, inner arm, and less commonly preferred sites are the leg, trunk, and forearm. So from the thighs, buttocks, inner arm, the grafts can be taken. If still some grafts are required, then you can take them from the leg, from the trunk, and from the forearm also. The graft is laid upon the recipient area and dressed. The part is immobilized and elevated to lessen the tissue edema. Usually the graft is taken up by 7 days. The donor sites heal in 10 to 15 days, depending upon thickness of the dermis that is removed. The donor sites also heal in 10 to 15 days. This is called the dermatome, skin grafting knife. So with that knife, you can take a slice of skin like this. This is the split skin thickness graft that is taken. After that is called the power dermatome. That is not required for you. So these are the donor sites you can see here. This is the thigh. This is the medial side of the thigh. This is the lateral side of the thigh. This is the posterior side of the thigh. So from these places, you can take the graft. You can take a very wide grafts you can take. So the graft is taken from the donor side thigh. So I have taken the graft from the thigh and I have placed it here. So you can see the raw area. This is all granulation. That means this tissue is capable of producing a lot of granulation tissue. So I placed it here, and then you can see the sutures. The graft is sutured so that there will not be any movement of the graft over the recipient area afterwards. There should not be any movement. If any movement is there, means the fine fibrin strands developing, they will break away. So what you must do, you must apply a pressure dressing here, keep the limb elevated, and make the patient to be in the bed without getting ambulated for 1 week. So the patient should have even the natural activities in the bed only. If he moves down and then walks, then there will be movement, and this will cause shearing force here for the fibrin bands, and the fibrin bands will break away. So after 6 months, this is the appearance you can see here. For example, we have seen large areas of burnt tissues can be there. So the whole trunk can be burnt. So when you want to graft that large areas, the donor areas will not be sufficient to do the grafting. So in that case, what you do is you do a procedure called meshing. When large areas of burn wounds have to be covered, mesh grafts are used. So what is this mesh graft? So this is a machine. This is called mesh dermatome. You pass the skin, that means you pass the skin graft what you have taken, split thickness graft what you have taken. You pass it through this mesh dermatome that will punch multiple holes. So because of the holes, it becomes like this. Now the skin can be stretched and you can place it over the large areas. And these act as epithelial islands. So in between them, this epithelium will grow and surface. So this will take up. But there will be thin layer of epidermis in between these vacant areas. But our intention is to surface the burnt area and to have some epithelialization so that there will be no oozing and there is not much scarring and deformity. So you can see this is the mesh dermatome, and you can see mesh dermatome is applied here. It's just like a mesh, it is all skin. Disadvantages of split thickness graft. Well, the split thickness graft is only useful not to have a raw area, not to have scarring. Because there is no scarring, there will not be any contracture. So that is the only advantage. Disadvantage, cosmetically poor. It gives a blackish or brownish area which over a period of weeks and months contracts slightly. Tends to contract because of lack of dermis. Dermis, if it is there, then there will be elasticity. But this graft has no elastic tissue, so it tends to contract. Cannot withstand trauma and pressure, hence unsuitable on palms and soles. So you cannot do split thickness grafting over the palms because palms and soles are always subjected for trauma and pressure and friction. So with that, this split thickness graft, it will go away. So it cannot withstand. So you should not apply it over the palms and soles. It cannot be grafted on bare bone, tendon, or cartilage, or infected and necrosed areas or over cavities. For example, if the fellow comes to you with an squamous cell carcinoma of the cheek, which has infiltrated from the skin to the mucosa, the whole thickness is being involved, then what you do? You have to remove this whole chunk of tissue. A hole will be left here, communicating with the oral cavity. Then you can't put a graft there because there is no underlying bed, it's a cavity. If underlying granulation tissue is there, means you can keep a graft, but otherwise over a cavity, you can't do it. So Wolf has come out with full thickness graft. All layers of skin, devoid of subcutaneous fat, is grafted. For its survival, a clean, well-vascularized base is required. It should have very good vascularization bed. It gives cosmetically acceptable appearance. Hence, it is frequently used to cover small defects on the face, especially after correction of ectropia. So the Wolf or Wolf graft or full thickness graft cannot be taken in large sheets, just like split thickness graft. You can take small areas and they are grafted over the face because face has high vascularity and face needs good cosmetics. If you put a partial thickness graft, that will just look like a stamp. A stamp of skin is being fixed there. But if you take a full thickness graft, that will have little better appearance than the partial thickness graft. So the Wolf's graft is used for the face, especially for the correction of ectropia. The full thickness graft is taken, it is a free graft. It is not with its blood supply. Because you are taking it as a free graft, for its survival, it needs blood supply. So if it is a large one, it can't survive. A small one placed over a very, very vascular area, then because of that high vascularity, this graft will survive. So Wolf's graft is not used frequently. It is used very, 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 very infrequently. It is only confined to the correction of ectropia. Otherwise, because it has no blood supply of its own, if you place it in some other area, it gets necrosed. Yes, the dermis has blood vessels. So those blood vessels, they get communication with the recipient area, blood vessels. For the recipient area to produce blood vessels into the dermis means the recipient area should have a very high vascular surface. So the donor sites for Wolf graft being postauricular area, root of the neck. So this is the ear. So you take the graft from behind the ear and you can place it over the ectropia, over the eyelids. Disadvantages: the graft take may be poor because the immediate nourishment of whole dermis from recipient's bed is usually inadequate. So graft take is poor here because it has its own blood supply is not there. So the blood vessels should grow into this dermis. It may not happen many times. So graft take may be poor. That is why now many of the surgeons, they don't go for Wolf's graft because of this disadvantage. Till 1 week or 10 days till you remove the dressing, you will be highly suspicious whether the graft will take or not. So to overcome this problem, the flaps has come into picture. What is a flap? Flap is a graft along with intact blood supply. It has the blood supply. So if you place the flap anywhere, because it has own blood supply, it survives there. It doesn't depend upon the blood from the recipient area. It has its own blood supply. Then how do you do these flaps? Let us see. Flaps are layers of full thickness skin with intact blood supply. The blood supply to the flap is achieved by various procedures. This raised flap is transferred to the recipient area. So the flap is raised and is transferred to the recipient area along with the blood supply. Advantages: it gives cosmetically better appearance. It can withstand trauma or strain like that of normal skin. So you can place this flap over the palm or over the sole. As this flap contains full thickness of skin, it doesn't contract. It can take up even on compromised areas of fibrosis, bare bone, tendon, joint cavities, cartilage, body cavities, where split thickness graft cannot be taken up. So this flap takes up well there. Types of flaps. It is a very big subject. It itself is a specialty of its own, that is plastic surgery. But as undergraduate students, what you need to know is only the basics of flaps. That is why I will just touch upon the basics of the flaps. Depending upon the method of achieving the blood supply to the flap, these are classified into local flaps and distant flaps. Local flaps means, again, there are four varieties: advancement flap, transposition flap, rotation flap, rhomboid flap. Then distant flaps, random pattern flaps, axial pattern flaps. Then pedicle or island flaps, free flaps, composite flaps, perforator flaps. So these are the various types of flaps, and just I will explain one or 2 points about each of these flaps so that you can understand the basic concept of taking the flaps. The flap is designed to cover the local defect by dissecting it in the subcutaneous plane by various procedures. The flaps survive by dermal vascular network, and hence, as they are lifted from the subcutaneous level, they can survive if they are raised for a great distance in the subcutaneous plane. For example, if you cut the dermis here from subcutaneous tissues and lift it off, for some distance you can lift it off because it will be receiving blood supply from the other end. But if you take a very long length of flap, this won't survive. So there are some rules for construction of these local flaps. So types of local flaps being advancement flap, rotation flap, transposition flap, rhomboid flap. These are the four varieties. Now you can see here, what is the advancement flap? An ulcer is here. This ulcer is X size. You try to suture it. Because the gap is more, you cannot approximate it. Then what you do, you make a incision like V just adjacent to this area of defect. You undermine the tissue. Undermine means separate the tissues from the underlying tissues. So you undermine from this area up to this area. So this gets lifted off from the underlying tissues. Now you suture this wound. So you can suture this like this because this is being pulled this way. So once it gets pulled like this, this V moves forwards. This part of the V moves forwards, and that leaves a Y gap. Now you can suture the Y gap. Did you understand this one? Okay, I will show you how Y is formed. So here the wound is sutured. So this V is pulled this way. So this much of gap occurs. Now what you do, you suture these two edges together. You suture these two edges together. Then you suture this together. Now did you understand? This is originally like this. So this defect, now this V is pulled this way. This has been pulled this way. So a gap has occurred here. So once this gap is there, you suture this tile. Then you suture these two limbs. This becomes Y. So now what you are doing here, you are making a V into Y. So this is also called as VY-plasty. This procedure is called VY-plasty. So this is called advancement because you are advancing this flap of skin forwards. Because this flap of skin is cut only here, it is having blood supply coming from this direction. So it survives. Then rotation flap. For example, here is a triangular defect on the scalp, for example. A triangular defect is there. The bone is exposed. You can't place a split thickness skin graft. You have to make a full thickness graft. Then what you do, the base of the triangle is extended. Incision is extended from the base of the triangle like an arc. Like an arc. So it should make a circle, complete circle. It should not be acute like this. It should be a clear circle. Then you lift this part of the skin. Lift it. And then you suture it here. So you are rotating this triangular flap in this direction. So that's why this is called the rotation flap. Then this is called the transposition flap. This is example is called the Z-plasty. First you make the incision. This is the scar tissue. You want to take away the scar tissue. So you do this procedure called Z-plasty, where you take two triangular flaps on either side, and this end is brought here, this end is brought here. So this will correct the contracted scar tissue. Of course, you cannot follow this. I will show you a video clipping on how you do the Z-plasty and how the contracture can be corrected. Then rhomboid flap also, I will show you how you do the rhomboid flapping. Advancement flap example, traumatic amputation of finger. For example, sometimes a patient may come to you with amputation of the terminal phalanx. He is working with some machinery. So he keeps the hands like this. So accidentally he may lose the tip of the finger. So it will be clean cut injury like this. This is the bone, this is the tissue. So you can't suture it here. Then what you do, you make a V cut over the pulp space. You make an incision deep up to the bone here. So this pulp of tissue, skin with subcutaneous tissues, they get blood supply from the underlying tendon and underlying periosteum. So you slide it forwards over this and suture it here. Then it becomes V becomes Y. So this is VY-plasty. So for cut fingertip, this advancement flap can be used. Another example for the rotation flap. So here a basal cell carcinoma of the cheek, it is being excised, and you take a big arc of rotation over the cheek and neck. You elevate this flap of skin, you rotate it, and then suture it here in this place. This is again another example of rotation flap. So you have removed this part of tissue, you make a arc like this, you separate this big flap of skin, and you rotate it forwards and suture it. You can see this is leg, and there is melanoma here. So the melanoma is excised over the tibia. Tibia is exposed. So you can't suture, you can't put a graft over the tibia. So that's why you take a big arc. So you can see this is the arc you have done. And this flap of skin is lifted. So this part of the skin is separated, lifted. So you can see, so the whole flap is lifted off. Then you suture it over the excised area. So how much arc you have to take, depending upon the site, there are calculations. So there is all, you will learn it in the plastic surgery. So basing on those calculations, you have to construct the arc like this. You may ask me why to make this arc like this, why can't you make only this much of arc? So whether the flap to survive, how much base should be there? So this is the base, where the blood supply is being derived. So how much base should be there, and how much arc has to be taken, all these, there are calculations. So basing on those calculations, the plastic surgeons, they will construct. This is again another transposition flap. This is Z-plasty operation. This is a scar here. The scar has contracted. If you excise the scar and suture it, because already there is contracture, so it will remain like that. You must lengthen it. So what you do is, you excise the scar, then you make a triangular flap on this side and another triangular flap on this side. That means you make a cut here and a cut from this side. So, sorry. So you are making it this particular scar excised area into letter Z like. So this is the flap, and this is the flap on this side. So you undermine the triangular area here, you undermine the triangular area here. So you can see the flap is being lifted off. So you have one flap this side, one flap this side. Then what you do, you place a hook on either side. So this is the scar. So you place hook on the either side and pull it like this. You stretch it. Then you place this flap here, you place this flap here. You can see this flap is placed here and this flap is placed here. Now you suture it. So it becomes an S shape. So Z will become S shape. So this is another example of transposition. So this flap is transposed to this area and this flap is transposed to this area. And again, to construct these triangles, so there are formulae are there. So you have to base upon those formula, you have to construct these triangles. Just I will show you one video clip of the Z-plasty. You will get some idea.
The Z-plasty is useful in lengthening wounds as well as reorienting the direction of scars. In this example,
now you can see here, this is the scar tissue. So you want to cut it and you want to lengthen this area. So you make a triangles like that and lift the or undermine the skin from the subcutaneous tissues. So you have a one triangle here, and this is second triangle. So that is one triangle, and this is another triangle. Now you transpose it like this. So that area now got lengthened, and suture them. This is rhomboid flap, where you take a square of tissue is removed. There is an ulceration is here, so a square of tissue is removed. And again, you construct another rhomboid here. So another flap, you take it here, then you turn it like this and suture it. So this is the rhomboid flap. Do you want to see the rhomboid flap also? A video clipping? In Z plus T, the scar is not there. You will remove the scar, you will excite the scar. For example, there is a scar over the side of the neck. The scar has caused contracture. So you remove the scar, construct triangles on either side, then you extend the neck. So the scar area is being now widened. So this flap will fall here and this flap will fall here. So there is no scar. Actually, the direction of the scar also has been changed here. So this is Z-plasty operation. To lengthen the area, this is contracted like this. Once you do Z-plasty, the neck can be brought like this. So it can be extended. This is done for the release of scar contractures. To release the scar contracture. Earlier, that scar area only is 2 inches. You can lengthen that area for 3 inches. Anyway, because you have doubt, I will show it again. Now you can see this is the scar, original scar. So this is contracted. We want to make it lengthened here. Instead of here, this should be this much size. Now you can measure the length from here to here. This is almost 1.5 times. Earlier the scar is like this. But once they removed it and did the Z plus T, the whole direction has been changed, and this area got lengthened like this. And to get lengthening, you derive the length from the sides, because you are pulling it this side and this side, so you will causing traction from the sides. So when the sides are lax, you can do this. For example, on the neck, if the neck skin is lax on the sides, then you will be able to do this. And these are the formula to do this. So how much angle should be there? So how much length you have to go for? So all these things, there are definite formula for that. So basing on those formula, you have to construct the Z plus T operation. Do you want to see the rhomboid flap also? You can see here, this is the lesion. That lesion is being excised. Now you construct. So first of all, you must draw. So how much angle you must have, all this formula will be there. Basing on those, you have to construct another rhomboid by the side. So the flap of skin is elevated. Then the margins are undermined. See, this is how you will construct it. So this is called the rhomboid or rhombic flap. So this is the local flaps construction. Then distant flaps. Random pattern flap and axial pattern flap, these are the two methods. Random pattern flap is direct distant, another is two pedicle. You take a flap of skin, this is random pattern flap, this is axial pattern flap. Yes, all the flaps should be taken only where the skin is lax. or else you have to go for the axial pattern flap. Now you can see these flaps. Now you can see here, this is random pattern flap. Random pattern, first of all, I will tell you about the axial pattern. Axial pattern means whenever the skin, the underlying tissues and the underlying muscle gets a named artery. A blood vessel is there, big blood vessel is supplying. So that blood vessel will ramify and supply the muscle, the overlying subcutaneous tissues, and the overlying skin. So if you know the blood vessel there, then you can make an incision around it, and you can take a long flap. You take this flap along with this blood vessel. So this is called like the axial pattern flap. Then there is another flap that is called the random pattern flap. Here there is no blood vessel, but what you do, you take a wide base and a short length. So you lift the flap and you can do the flap procedure. So random pattern flap, skin flap is raised with a breadth to length ratio of 1.5 to 2:1. So if the length is 1 centimeter, the base should be minimum between 1.5 to 2 centimeters. Blood supply of the flap is not considered here. So you don't look for the blood vessels. Anywhere you can construct this random pattern flap. Now, for example, here, this patient is having an ulcer over the tibia. The ulcer is being excised. So bone is exposed. Because bone is exposed, you can't place a split thickness skin graft here. You have to go for a flap. You can go for a rotation flap, which already I have shown you. Or you can go for this random pattern flap. What you do in this random pattern flap, you take the flap from the adjacent leg, the other leg, the counter leg. You take a flap like this, and the base is 2 times the length. This is the length and this is the breadth. So you construct a flap and you switch this flap to this wound. Then you apply PVP plaster for both these legs. So both these legs must be immobilized for this flap to get attached here. This is something like what you do in the plants. The plant stems are being reimplanted. So in the same way, this is done here. After 3 weeks, you cut this flap here. Because by 3 weeks time, it gains attachment here and gets new blood supply from this area. So once it got a new blood supply from here, you cut it off. And the donor area, there is a over defect there. So that defect is over the muscle, over the calf muscle. So you can place a split thickness graft to cover the defect there over the donor area. Earlier I told you indications for skin grafting, one of the indications is to cover the flap donor defect. So this is the flap donor area on the back of the calf. So that flap donor area, you can do a split thickness grafting. For example, over the forearm, there are various tendons are there, extensor tendons. Over the tendons, the partial thickness graft cannot take up. So you take a flap from the abdominal wall, place the forearm on the abdomen and place this flap over this here and suture it and immobilize it for 3 weeks like this. This is called cross-finger flap. A flap is constructed from the dorsum side of the finger, of the other finger, of the adjacent finger. And that flap is placed over the pulp space. Because pulp space is subjected for a lot of pressure, friction, trauma. So you should have a full thickness graft. So you can place a flap cover here. Partial thickness graft will not take up here. So these are the examples of random pattern flap. cross leg flap, cross finger flap, abdominal flap to the dorsum of the hand. These are some examples. Of course, this is the two pedicle flap. It is not being done nowadays. So I will skip this. Then axial pattern flap. Okay, axial pattern flaps. The flaps are designed based on the known artery and vein supplying a territory of the skin. Breadth to length ratio need not be maintained because it has its own blood supply. Long strips of skin flaps can be raised. Types, you can raise skin and fascia together. That's called fasciocutaneous flap. You can raise muscle skin also. Then it's called the myocutaneous flap. You can raise muscle bone skin also. Then it's called osteomyocutaneous flap. These flaps are very useful in reconstructive surgery after wide extensive resections, as in malignancy or after trauma. So this is called the deltopectoral flap, where you take the flap from the deltopectoral region and you place this graft over the donor as a recipient area. So example, you can see here over the cheek there is a big ulcer. So you take a deltopectoral flap and place it here. You can see here, this is the dorsum of the hand. There is big loss of skin with exposed tendons. Now this is the groin region. Here is the inguinal ligament. And here is the circumflex femoral artery and vein. So the skin overlaying this, you can take a flap of skin like this, based upon this circumflex femoral artery. So this flap is taken. The hand is brought here and placed here, and this flap is sutured to the skin here. So the skin is sutured here in this place. And the hand will be immobilized for 3 weeks. The graft attaches there and it receives new blood supply from the donor, so from the recipient area. Then after 3 weeks, what you do is you cut it here. You cut here and again place the remaining tail over the recipient area and suture it. If any defect is there in the recipient area, you can place a split thickness graft to cover the defect. So you can see here, this fellow has crushed injury of the hand. So there is traumatic amputation of the fingers with loss of skin of the dorsum of the hand and palm of the hand. So a groin flap is constructed here and it is placed over this area. Pedicled flaps. The blood supply of the flap can be pedicled so as to swing it around on a stalk to graft it at a distance. You can see here, this is axial pattern flap. You raise the flap and you place some other structure there and you can graft it here. But once you make it like this, like a pedicle, then what you can do, you can move this way, that way, that way. So you can rotate it. Example, pedicle flap, latissimus dorsi flap, transversus rectus abdominis flap, like this. So you see here, this is pedicle flap. There is ulcer on the heel. You want to heal it. So you want to put a graft there. So what you do is from the instep of the foot, it is not weight bearing area. So this is all the weight bearing area. This is not the weight bearing area. So you take a flap of skin with the medial plantar artery. Then you lift the flap along with the blood vessel. The blood vessel is being pedicled. You separate the tissues under this part of the skin. Then through this tunnel, you get this flap here and place it here. So the flap is placed here. The artery is coming like this. So this flap survives. Then what is this? This is the donor defect. So this donor defect area is grafted with split thickness graft and it heals. Because non-weight bearing area, you can apply split thickness grafting here. So this is pedicle flap. Already we have seen tram flap for the reconstruction of the breast. So we have taken the rectus abdominis muscle. So what we have done, we have cut it at the lower end. Then superior epigastric artery supplies this rectus abdominis muscle. So you separate this muscle up to the costal margin. But the attachment to the superior epigastric artery is kept intact. Then you turn this flap here, muscle here, and place it in the raw area here and suture it. So this is the tram flap. Similarly, this is the blood supply coming to the latissimus dorsi muscle, thoracodorsal artery, coming from the axilla. So you take this, it is a very wide origin. So this wide origin is scraped off. The whole muscle is lifted off. So now the muscle is, once it is separate from the origin, it only hangs from the axilla. So this forms a pedicle. Now you swing this muscle anteriorly and place it over the front of the chest and do the flap repair for the breast site. This is another example of flap. This is called pectoralis major myocutaneous flap. So there is a defect here over the face. So what you do is you want to take this graft along with the island of skin, the underlying pectoralis major muscle, and if you want, you can take even the ribs also along with this. You can see this is the island of skin, subcutaneous tissue, which is left adherent to the muscle underneath. The whole pectoralis major muscle is being lifted off. The whole pectoralis major is being separated here. Now, you detach the pectoralis major muscle from its attachment to the costal surface, to the ribs and costal cartilages. So it has insertion into the humerus. So from there, it gets the lateral pectoral artery. So artery is coming from this side. So you can detach it from the origin. So the muscle, along with the island of skin overlaying it, is being lifted off. So you can see, this is the pedicle, where lateral pectoral artery is coming here. So this is the muscle. And to the muscle is attached the skin. So you take this muscle along with the skin into the neck, under the skin here. So this is the skin here. So you make a tunnel under the skin and you take it here. You can see. So this is the tunnel under the skin. So the whole muscle is taken out, take up into the neck through this tunnel. And you place it in the raw area here. For example, the patient had undergone hemimandibulectomy with blocked dissection of the neck for carcinoma of the cheek or carcinoma of the mandible. So you remove the mandible, you remove the cheek muscles, everything. So there is a big defect here. So you take this pectoralis major muscle along with the underlying bone plus the overlying skin, everything can be placed here. So these are all the axial rotation flaps or axial pattern flaps. Free flap, a flap of skin with its supplying artery and veins is removed from the donor area and grafted to the recipient area with anastomosing the vessels of the flap to the nearby vessels by microsurgical technique. For example, just now I told you about hemimandibulectomy. If a person has undergone mandibular removal, the overlying cheek is also removed. Then to reconstruct the mandible and the overlying cheek and skin, what you can do is you can take the radius bone, along with it overlying brachioradialis muscle, along with the skin overlaying it. So the whole thing you take it. The radial artery also you take it. So you take the whole piece along with the radial artery and place it here and anastomose the radial artery to external carotid artery by microsurgical technique. So this bone, this muscle, the skin will survive and you do the reconstruction of the mandible. You can see here there is a big crush injury of the foot. This is the foot. The muscles and the bones have been lost with exposure of the bones here. So then what the surgeon has done was he has taken a big flap of latissimus dorsi muscle along with it overlying skin. So that was excised. So you can see this is the latissimus dorsi muscle and this is the thoracodorsal artery. He took this, placed it over the foot, and the artery is anastomosed to the radial artery. Sorry, the tibial artery. Now you can see the end result. So the crushed limb has regained its function. It cannot have the normal shape. A normal texture is not there. It is mainly for functionality. Of course, these are the calm muscles which can be taken. These details are not required for you. If you just remember that a free flap is taken along with intact blood supply, with blood supply, and the blood vessels are anastomosed at the donor site. Composite flaps means if you do the grafting of composite tissues, skin, subcutaneous tissue, the muscle, the bone, is called the composite flap. Of course, this is also not required for you. So this is about the skin grafting. What you have to remember is there are two types of grafting. One is skin grafting, other is flap construction. What is grafting? It can be split thickness graft that is done usually. The full thickness graft is done occasionally to cover the defects on the eyelids, small areas, and graft take-up is doubtful for full thickness graft because it has no intact blood supply at the new place. The graft may not take up. So if you want to have cover a recipient area which is having bare bone, bare muscle, bare tendon, bare cartilage, or cavities, or infected area, or irradiated area, you have to go for flaps. Flap is, it can be made of skin. It can be made of skin plus underlying subcutaneous tissue and deep fascia. Then you call it as fasciocutaneous flap. It can be taken up with the skin, fascia, underlying muscle. It is called then myocutaneous flap. It can be taken up along with the skin, the muscle, and underlying bone. Then it becomes the osteomyocutaneous flaps. So there are two types of flaps: random pattern flap, where the breadth to length ratio of the flap is 2:1. Then there is axial pattern flap, where a blood vessel will be there for the flap to supply its nourishment. So basing on the blood vessel, you construct the flaps with the skin, fascia, muscle, bone, with the required things. So these are very useful for reconstruction of defects produced after major cancer surgeries and after major traumas. This much if you know, that is more than adequate. Any doubts, please? So if you have no doubts, we will proceed to the next topic, that is the skin and soft tissue lesions. Okay. Manogya, it seems you have a doubt here. Just now I have seen this doubt. When blood supply is not considered, what is the difference between this and the graft? Are you asking about random pattern flap? Random pattern, it is a flap. Example, cross finger flap. You take the skin from the dorsum here. You lift it like this and you place it here. So it is a flap. Here you are not considering the blood supply, how the blood supply is coming. But you are taking the flap, keeping the breadth is double the size of the length. So the graft survives. That is the principle. So whether distal artery is there or not, you don't bother. Okay, now we'll go to the topic of the skin and soft tissue lesions. First, I will tell you some terminology about the common skin lesions. Macule means a flat, impalpable lesion. That means there is a lesion on the skin, but it is not palpable. That means it is not elevated. That means any pigmented area on the skin is called the macule. Papule, a small elevated lesion less than 5 millimeters is the papule. Nodule, an elevated flat lesion more than 5 millimeters. Plaque, an elevated flat lesion larger than 2 centimeters. A cyst, a swelling containing fluid lined by epithelium or endothelium. Vesicle, an elevated skin lesion containing fluid. Pustule, a raised lesion containing pus. Nevus, a birthmark. Mole, a blemish on the skin due to high content of melanin. Ulcer, dissolution of cells of epithelial surface due to molecular death of cells. So these are some of the definitions as regard to the skin lesions. First, let us study about the skin lesions. The structure of the skin, it has the epidermis. Just now we have discussed about the epidermis. It has the basal layer and there is keratin layer. It has hair, sweat glands, sebaceous glands. The sweat and sebaceous glands, they dip into the dermis. Here are the sweat glands. There are blood vessels supplying to the dermis. Sweat glands, there are two types. Eccrine means situated over whole of the body, more on the thick skin. Secretes clear watery sweat due to heat and emotions. They are controlled by cholinergic sympathetic fibers, hence blocked by atropine. So they are sympathetic fibers, but the sympathetic nerve endings, acetylcholine is released. For all the other sympathetic nerve fibers, there will be release of adrenaline and noradrenaline. But for the sweat glands, the sympathetic fibers, they liberate acetylcholine. That is, they are the cholinergic sympathetic fibers. Hence, they are blocked by atropine. The other type of sweat glands is the apocrine glands. These glands are situated in the axilla, pubis, umbilicus, perineum, and areola. They are active after puberty and do not participate in temperature control of the body. They are stimulated by adrenergic, sympathetic, and secrete during emotions. The secretions are odorless but emit characteristic odor due to bacterial colonization. Mammary glands, glands in the external artery meatus, glands of eyelids are all modified apocrine glands. Then, after sweat glands, now let us discuss about sebaceous glands. They are situated on whole of the body except on the palms and soles. They open into the hair follicle or directly onto the skin. It opens onto the skin over the face, lips, areola, and glans penis. They secrete oily substance called sebum. Sebum is produced by liquefaction of the alveolar cells. The lining cells, they get liquefied, and that is secreted out as the oily substance onto the surface. That means the oil is not being produced. It is only due to liquefaction of the alveolar cells of the sebaceous glands. Once the one layer of alveolar cells get liquefied, then the underlying cells, they again regenerate and form new alveolar cells. Sebum protects the skin by preventing dryness, and the free fatty acids have antimicrobial properties. Prevents heat loss by forming insulating fatty layer. They become more active during puberty due to surge in the sex hormones and develop into acne, later get adapted to sex hormones and acne disappears. Lesions of skin which are of surgical interest. I'm not going to tell about everything about dermatology here. So only surgical lesions I am going to tell. They can classify into masses and ulcers. Clinical features of skin lesion is the lesion moves with the skin and skin cannot be pinched over it. So if it is a skin lesion, you can't pinch it. And if you move the swelling, the skin moves. If you move the skin, the swelling moves. So if the skin is pinchable, means it is not a skin swelling. Causes of skin swellings: infections, cyst formation, hematomas, tumors, benign and malignant. Infections: acute folliculitis or furuncle, carbuncle, abscess, erysipelas. Then chronic condyloma, nodular leprosy, hydradenitis suppurativa, granuloma pyogenicum. Cysts: sebaceous cyst, dermoid cyst. Dermoid cyst is not from the skin. It is not in the skin. It is subcutaneous lesion, but it is derived from the skin. That is why this is being included here for our discussion. So though it arises from the skin, it lies subcutaneously. Then hematomas, neurofibroma, hemangioma, and mole. Tumors: benign tumors from the sebaceous gland, that is sebaceous adenoma. Benign tumors from the sweat glands, then cylindroma, syringocystadenoma, hydradenomas. Then another lesion called the keratoacanthoma from the basal layer of the epidermis. Papilloma. There are two types. One is the squamous papilloma or Wharton. Then other is the basal cell papilloma, also called the seborrheic wart. Malignant tumors: epithelial tumors, epithelioma or squamous cell carcinoma, basal cell carcinoma, melanoma, secondaries. Then miscellaneous tumors, mesenchymal tumors, that is from the dermis. The dermatofibrosarcoma protuberans, Kaposi sarcoma, then lymphomas. Anyway, you please again go through the textbook for the classification, because there are too many are there. It is better if you review it again. Then ulcers of skin, non-specific being traumatic ulcers, ischemic ulcers, venous ulcers, trophic ulcers, malnutrition ulcers, and infectious ulcers. Specific ulcers due to some specific disease like infection like tuberculosis, syphilis, soft sore, actinomycosis, or malignant ulcers, epithelioma, basal carcinoma, melanoma. So this is the classification of these skin swellings and ulcers. Infections of the skin: furuncle is nothing but infection of the hair follicle. This is carbuncle. What is the definition of carbuncle? What is the definition of carbuncle? Very good. The spreading infective gangrene of skin, subcutaneous tissues, and the kidney. Very good. And this is the erysipelas, and it is an abscess. Cysts of the skin. The word cyst is derived from the bladder. Definition: a sac containing fluid lined by epithelium or endothelium. Types of cysts: true cysts and false cysts. True cysts, cysts that are lined by epithelium or endothelium. Congenital, acquired, pseudocysts or false cysts. They are a collection of fluid that do not have any lining. Example: pancreatic pseudocysts, cystic degeneration of the tumors. The congenital cyst classification: sequestration dermoids, tubuloembryonic dermoids, cysts of embryonic remnants. Acquired cysts, cysts of retention, distension, exudation, cystic tumors, implantation dermoids, trauma, degeneration, and parasitic cysts. Parasitic cysts being hydatid, trichiniasis, and cysticercosis. Clinical features of a cyst: smooth spherical swelling. Fluctuation is present if the contents are not under tension and are completely fluid. So this is how you elicit fluctuation. This is the swelling supposed to be the cyst. So what you must do is you must hold the swelling on either side with your two hands. So thumb and middle finger, they will steady the swelling. Thumb and middle finger. Then with index finger, you press on one side and appreciate the movement of the fluid inside with the other finger. So first you do it one direction, then you do it in the other direction. So this is in one direction, then this is in the other direction. In both the directions, the fluctuation must be positive. Then only you say it is true fluctuation. In small swellings, Page's test is useful to elicit this sign. Do you know Page's test? Page's test for small swelling, small cystic swellings. What is Page's test? Do you know or not? Page's test means if a swelling is there, small swelling, what you do is with your index finger, no, use only index finger. With your index finger, you press at the center, press at the periphery. If it is a cystic swelling, the swelling is more soft at the center than at the periphery. If it is a solid swelling, it is more hard in the center than at the periphery. So this is called the Page's test. This sign is also present for any fluid collection like cold abscess. This fluctuation sign is also present for any fluid collection like cold abscess and very soft lipomas. Then the other clinical feature of the cystic swelling is translumination. the contents are clear. Cysts may manifest due to pressure effects on the surrounding organs. They may manifest due to complications. The complications of any cyst. You tell me, what are the complications of any cyst anywhere in the body? Yes, very good. Infection, rupture, hemorrhage, torsion, calcification, and sometimes maybe associated with cachexia. That is, of course, very uncommon. So this is the test of transillumination. This patient is having a large ovarian cyst and she is having cachexia. This is called cachexia ovarica. Now let us study about the individual cysts of surgical importance. Dermoid cyst. Types of dermoid cyst: sequestration dermoids, tubuloembryonic dermoids, teratomatous dermoids, implantation dermoids. So these are the 4 varieties of dermoids. When you study the wall of the dermoid cyst, you will see under microscope it is lined by epidermis and papillary dermis with sebaceous glands and hair follicles and contains sebum, degenerated cells and hair. So its wall is almost composed of structures similar to that of skin. Epidermis, dermis, sebaceous glands, sweat glands, hair follicles, sebum secretion, all these things are there. That is why it's called dermoid, just like skin. Sequestration dermoids, etiology. How the sequestration dermoids have formed. Wherever 2 ectodermal surfaces join together during development, burying or sequestration of part of the epidermis may occur, leading to cystic mass subcutaneously. The cyst is lined by epidermis and dermal structures, contain paste-like epithelial discominium. So you can see how the dermoid is developed. This is the ectoderm, and this is the mesoderm, and this is the enteroderm of the embryonal plate in the primitive stage in the first few days of life. So this embryonal plate is having ectoderm, enteroderm, mesoderm with central notochord. The middle part of the ectoderm, it differentiates into a specialized tissue that's called the neural plate. This neural plate, it dips deep, so it folds itself deep, so forming a canal here. So this is the neural canal. Now this is the neural canal, and when it gets folded like this, then automatically gets separated off. So it gets separated off and form a tube here. Sometimes what happens, along with it, a piece of ectoderm also gets separated off and forms an island of ectoderm. This is called the sequestrated ectoderm. This neural canal burrows deep and now forms into this brain and spinal cord. The sequestered ectoderm, because it has sebaceous glands, it has sweat glands, it has epidermal layer. So the epidermal layers exfoliate. Sebaceous gland they secrete a lot of sebum. So it gradually enlarges by collection of this pultaceous material inside it. The surrounding mesoderm differentiates itself into bones, skull bones, and vertebral bodies. So this is the sequestrated part which forms into dermoid. This is the underlying bone. Because a mass is here, the bone is not developed well here under the mass. So there will be a depression over the bone. And the neural canal is developing into brain. So now the dermoid is situated in the subcutaneous plane. Sometimes the dermoid will be large in size. It will be in the middle of the mesoderm. So the mesoderm cannot unite here. So there will be a hole in the skull bone. With the result, part of the dermoid is outside the skull and part of the dermoid is within the skull. So this is called a dumbbell dermoid. On rare occasions, the sequestrated epidermis may grow deep to the mesoderm and form an intracranial dermoid like this, with compression effects on the brain. So these are the types of dermoid formation. So the dermoid is formed from the sequestrated epidermis. The sequestrated epidermis, how it forms? It gets sequestrated when epidermis gets infolded to form the neural tube and neural canal. Along with the neural canal, the part of the epidermis may get sequestrated, and the sequestrated epidermis will grow into a cyst. The cyst may be there outside the bone or in the middle of the bone or deep to the bone. So where the dermoids can occur? Along the lines of embryonal concrescence. Concrescence means joining of two halves. So this line of embryonal fusion goes from the root of the nose, going back to the middle of the lower lip. So it starts from the root of the nose. Then it goes backwards. So it again comes like this. Except the middle part of the face, where nose and upper lip are there, the remaining part of the whole body, whole trunk, is formed from two halves. The epidermis join here. Actually, it is not in two halves which is coming and joining. So there will be infolding of epithelium to form the neural duct and neural tube. So along with that, there will be sequestration. So the dermoids can occur at the root of the nose, at the sacral region, in the perineum, near the umbilicus, midline of the neck. So, number one, the dermoids, sequestration dermoids can occur at the lines of embryonal concrescence. The second site of a dermoid occurrence is along the fusion lines of face and neck. Face and neck are developed from processes. These processes they unite together. So the dermoids can be there at the outer canthus of the eye, that is external angular dermoid. Rarely it may penetrate to the dura, or anti-triangle of the neck, that is the branchial cyst. This is the fetal face in the early weeks. So the face is formed from 5 processes. The frontonasal process in the midline, two maxillary process on either side, then two mandibular process, one on either side. In the center, there is a gap. This gap is the stomodium, which forms into the mouth and nasal cavity. So these, they grow and then they join together. That's how the face is formed. So at their union places, there can be development of the sequestration dermoids. So just now we have seen wherever two embryonal tissues join together, the epidermis get buried and may form into a dermoid. So this is the maxillary process developed area, and this is the frontonasal process, and this is the mandibular process. This is the stomodium. So the commonest places of development of the dermoid is at the outer canthus of the eye. This is the neck. The neck is developed from 5 arches. These are called branchial arches. Sometimes what happens is the second arch, it overgrows the other arches. You can see here the second arch is overgrowing the other arches and comes down and meets the 5th arch. These arches are lined by ectoderm on the outside. This yellow line is the ectoderm, and this black line is the entoderm, and the middle is the mesoderm. So the second arch may have a process-like thing which goes down and meets the 5th arch. So while it is meeting like this, what is happening here? There is an ectodermal island is being left behind here. Superficially, it is covered by second arch. Deeper, it is lined by third and fourth arches. So this sequestrated area becomes into a cyst here, because this is all epidermis. It has epidermal layers which discriminate and degenerate. It has sebaceous glands which secrete the fatty sebum. It has hair follicles which denude. So all these things mix here and form a pultaceous substance. So this is one type of dermoid. Because this dermoid is developed from branchial arches, this is called as branchial cyst. So the third place of development of dermoid is at the fusion lines of ear tubercles. External ear is developed from 6 tubercles. This is how it develops. These 6 tubercles, they fuse together and form the external ear. So at the junctional lines of these tubercles, there can be development of dermoids. And say this is a dermoid here. So common sites of orientation: midline of the neck, lateral angular dermoid, branchial cyst, periauricular dermoid. So these are the common sites of dermoid occurrence. Clinical features: it is a subcutaneous cystic swelling in the midline or at the junctional lines. It may grow to enormous size. Underlying bone shows excavated area, because presence of dermoid will impede proper development of the underlying mesoderm into the bone. So that is why there will be a shallow area where dermoid is present throughout the bone. It may be attached to the dura by a fibrous stalk passing through the suture line. It may have a dumbbell connection. Dermoid at the root of the nose may have a dumbbell connection. Sometimes it may lie completely within the bony cavity. Example, intracranial may lie in the vertebral canal, in the sacrum, or substernally. This is an example of median nasal dermoid. You see here, this is median nasal dermoid. You can see here, this dermoid is here. This is the dermoid. So this is one of the very commonly seen site of dermoid, external angular dermoid. It can be large like this. So this is again another external angular dermoid. So external angular dermoid is very common presentation of sequestration dermoid. It is due to sequestration of epidermis between frontal and maxillary process. This is the periauricular dermoid. You can see front of the tragus of the ear. Then this is another periauricular dermoid. This is due to sequestration of epidermal elements during formation of pinna from 6 tubercles of the ear. Of course, this is dermoid, angular dermoid. The patient has fallen onto the ground. The dermoid got ruptured and all its material has extravasated subcutaneously. Differential diagnosis, you are differentiated from sebaceous cyst and from lipoma. That is about sequestration dermoid. Next is the tubuloembryonic dermoid. These occur in the tract of ectodermal tube of embryonic origin. Examples: thyroglossal duct producing thyroglossal cyst, postanal gut, a small part of the hindgut projects backwards beyond the anal membrane. It is called the postanal gut, and from there the postanal dermoid can develop. Then teratomatous dermoid, these occur from the totipotent cells representing ectoderm, mesoderm, and entoderm. So whenever the totipotent cells are present, wherever they are there, from there a cystic mass can develop because they have epidermal elements. These epidermal elements will produce the degenerated epidermis, the sebaceous glands producing sebum. So they resemble something like dermoid. So the teratomatous dermoid, because of their ectodermal elements, they may have sebaceous tissue, hair follicles and hair, and sometimes even tooth may be there inside the dermoid cyst. Of course, in addition to that, there will be contents from mesoderm, contents from the entoderm also. The sites of teratomatous dermoid are in the testis, ovary, mediastinum, and retroperitoneum. Rarely it occurs in the sacrococcygeal area of primitive knot. Of course, this is the sacrococcygeal area. So first there will be a heap of the embryonal cells here. These embryonal cells, they later spread to various parts of the fetal disc. So this initial part is called the primitive knot. So the primitive knot area may have certain embryonal cells left behind even after the birth. So from there, the teratomatous dermoids can occur. So you can see here a patient with ovarian cyst. The mass was excised, and when it was opened, you can see all this paste-like material. This paste-like material is nothing but the desquamated epithelial cells which are degenerated. Then you can see a lot of hair. So this is one of the features of the teratomatous dermoids in the ovary. This is the ovarian cyst. So this is about the sequestration dermoids. Tubular membrane dermoids, example is the thyroglossal cyst. Then teratomatous dermoid. So one of the example is the sacrococcygeal teratoma. Sometimes you will be given in the examination about the dermoid as an essay question or as a short notes question. Sometimes you will be given only sacrococcygeal teratoma. What is sacrococcygeal teratoma? These cysts contain derivatives of the ectoderm producing hair, teeth, sebaceous material, then mesoderm producing muscles, cartilage, and enteroderm producing glandular tissue. Teratomas occurring in the early infancy and childhood are extragonadal, and sacrococcygeal region is the commonest site. So sacrococcygeal region is the commonest site of this extragonadal teratomatous dermoid. Gender incidence is most common in females. Pathology, it may present as a cystic, solid, or mixed lesion. Most neonatal teratomas are benign. Clinical features, it presents as external presacral mass protruding between the anus and coccyx. So it initially starts as a mass between the sacrum and coccyx behind and anus in front. It can attain large size and may even obstruct the labor. Sometimes it can form a complete organ that is called mature coccygeal sacrococcygeal teratoma. You can see here, this is one form of sacrococcygeal teratoma where a limb has formed here. So sometimes a complete organ may form. That means these totipotent cells, they develop into an organ. Treatment, complete surgical excision along with coccyx via sacral approach. If intra-abdominal extension is present, combined abdominosacral approach is made. Prognosis, it may recur even if it is benign. Then is the implantation dermoid. This is not a congenital one. This is acquired. This occurs due to implantation of living epithelial cells beneath the skin surface due to penetrating wounds forming a cyst. For example, a tailor is there who is in the habit of suturing the clothes or stitching the clothes with a needle. So sometimes the needle may penetrate his finger. So when the needle penetrates, some of the epidermal cells that are there on the surface may be driven along with the needle into the subcutaneous tissues. Then these epidermal cells, they develop into a cyst. So this is called the implantation dermoid. Sites of occurrence, palms and soles. So they occur usually on the palms and soles. Sorry. Treatment of dermoids, excision of the cyst, including the cyst wall. So these are the cysts of the dermoid cysts. Then we will stop it here, and tomorrow we will study the remaining cysts and lesions of the skin. Any doubts? We will have a number of topics here. Each topic is only very short. So because there will be too many topics will be there, you get confused one between the other. So please read the topic as it is being finished here. So at the end, we will have some case discussion on the skin and soft tissue swellings. Now, Santi, you asked a very genuine question. Can this occur with after injection? with the needle prick can occur after vaccination, definitely. But we don't see. These things are seen mostly in the palms and soles of the feet. So probably the keratinized thick epidermal layers may be responsible. If you do intramuscular injection, you don't find a dermoid there. No, they don't occur. Don't ask me why, because I have no answer. Probably you are right. Constant repeated trauma. Okay, that's fine. Thank you very much. See you tomorrow. And let's continue the topic of the skin and soft tissue lesions. Wish you all good night. See you tomorrow.